Good morning or good afternoon, everybody, wherever you are. We're going to start now the session entitled The Impact of the COVID-19 Pandemic on Breast Cancer Management. And before starting this session, I'm proud to announce the inauguration of the Egyptian Society of Breast Imaging as a sub-society of the main official Egyptian Society of Radiology and Nuclear Medicine. The EGSBI is a nonprofit organization that aims to create and maintain a rewarding and inspiring environment to breast imaging radiologists. The EGSBI is determined to fulfill the prerequisites of breast imaging radiologists to receive an up-to-date quality education that addresses the advances and worldwide guidelines in the field of breast imaging and intervention. And actually, our collaboration today with Omnia Health Africa is considered the first, let's call it online or on-ground actual activity for the society. We'll start the session now, which is the impact of the COVID-19 pandemic on breast cancer management. We have with us as panelists representing radiologists are the Dr. Marit Al-Madawi, Assistant Professor of Radiology, Mansoura University, Dr. Amal Higazi, Breast Imaging Consultant at Ayadi Al-Mustaqbal Cancer Center. Dr. Heba Azzam is an Assistant Professor of Diagnostic and Interventional Radiology, Cairo University. Representing oncologists are Dr. Amani Hilal, Professor of Oncology in the National Cancer Institute and Bahia Hospital, Dr. Shaimaa Lashin, Lecturer of Oncology in Cairo University, and representing surgeons, we have with us Dr. Mahir Hassan, Assistant Professor of Oncology in the National Cancer Institute and Bahia Hospital. Our case presenters today are Dr. Sahar Mansour, Professor of Radiology, Cairo University, Bahia Breast Cancer Hospital, Dr. Iman Awais, Breast Imaging Consultant at Wafi Center, National Screening Program, Dr. Sara Zaytoun, a surgical oncology consultant at Dar es Salaam Oncology Center and in Bahia Breast Cancer Hospital. The cases presented today are from Wafi Center and from the Bahia Breast Cancer Hospital. Definitely, the COVID-19 pandemic has affected every aspect of life, including the breast care practice. The pandemic has affected screening, diagnosis, treatment, and even the follow-up of breast cancer patients. Breast cancer patients and care providers have both found themselves in an exceptionally difficult and uncertain position since the coronavirus pandemic began. All over the world, cancer care was delayed and many surgical procedures were even canceled at the beginning of the pandemic. Any unnecessary and non-emergent procedures stopped, like screening, benign operations, and reconstructive surgery were postponed. Another challenge that breast cancer providers had to address was that many patients have abstained to seek care out of fear. Even patients with diagnosed breast cancer were hesitant to come into a healthcare facility to receive further management, knowing that they are immune compromised. As a result of this unprecedented situation, after the pandemic has relatively subsided, we are now seeing many breast cancer patients with advanced disease. And knowing that the coronavirus pandemic will be with us for a long time, it has become essential to ensure breast patients that they will receive the quality care that they deserve while ensuring that they are safe in all other aspects. The outcomes of women with breast cancer are dependent definitely on the timely and high quality interventions. And any delay in this timely management will impact both the physical and psychological status of these women. As the pandemic progressed, breast cancer institutes and units had to implement new protocols and to elaborate new workflows for patient management, and they had to arrange new procedures to keep providers, staff, and patients safe. The logistics of the flow of patient care had to be re-evaluated to minimize personal interactions and to prevent the transmission of the virus while keeping both patients and breast care providers as safe as possible. And today in our panel, we're going to represent three different cases who were really affected by the pandemic.
Right. Well, first, I would like to thank the Egyptian Society of Breast Imaging for giving us all the Egyptian radiologists and the oncologist surgeons the opportunity to give the experience we have passed through during the pandemic of coronavirus and its impact on the breast cancer patients. My case is 52 years old. It is a postmenopausal female, and she came for screening mammogram on November 2019. This is the mammogram, her annual mammogram. What do you think is the abnormality that you can detect in this mammogram? Dr. Mirad, Dr. Hiba.
There is an asymmetrical density seen in the right breast upper outer quadrant, and here in the mediolateral oblique it can be detected just anterior to the axillary fold.
This area?
Yes.
Okay.
It's a focal asymmetry. I see it in both views. I think it's also seen in the CC view outer.
Okay.
Yes.
This mammogram, we can see here, we can appreciate an area of asymmetry in the upper outer quadrant of the right breast.
Also, the axillary lymph nodes are seen markedly enlarged.
Okay.
Yeah,
so we have a
hyla.
little bit abnormal size and configuration of the lymph nodes. Actually, we all know that the mammogram is not the modality for discrimination of the lymph nodes. However, we have to consider them for an ultrasound. Then you think we should go to the ultrasound, or anything abnormal here in the mammogram we have to discuss?
I think we should proceed to the ultrasound.
Okay. So our BIRADS here in the mammogram is BIRAD 3. You are okay with that, or you would like to give it BIRAD 4?
No, 3 is enough.
Okay.
I think if she's a screening, she's screening.
It's a screening mammogram. It's first time
she's a screening. So the patient done her mammogram and left. So it's a BIRAD 0 because we need to pull her back and and do ultrasound.
Okay. So up to now, we can consider the mammogram it's BIRAD 0 until we can see what's the abnormalities correlating for in the ultrasound images. On the ultrasound, we have here the area at the upper outer quadrant, which is called the MLO of the mammogram. And here in the ultrasound, it's more or less it seems to be a glandular tissue. Or do you have other ideas?
It's just an area of prominent glandular tissues and ducts.
Yes, and we could consider it a glandular tissue island, or it's have no significance. Maybe accepted some asymmetry between the two breasts. Then we want to...
Dr. Safar, I think we should ask for a follow-up for this patient.
Yes, I'm just discussing the findings on the ultrasound. Okay, then we have to inspect for the lymph nodes. On the lymph nodes examination, they a little bit seems normal, non-specific nodes. Even the asymmetrical cortical technique, it doesn't exceed 2 to 3 millimeters.
Okay.
On the ultrasound, we had found these dilated ducts, which wasn't evident for us on the mammogram the first time. And there is increased vascularity surrounding the ducts. And when we go back to the mammogram, we can appreciate here on the other side seems to have such tubular and linear asymmetry in the retroalveolar region. So now our BIRAD will be
4.
No, I think we should take 3 with the and do a close term follow-up.
Close follow-up.
Close term follow-up, and for BIRAD 3, still BIRAD 3, and take a close term follow-up. Okay. Well, the patient actually will give him BIRAD 3, as we may consider that these findings is an upper outer quadrant asymmetrical density at the retroalveolar dilated ducts with surrounding abnormal vascularity and abnormal contour, maybe due to likely periductal mastitis, and the patient was subjected to follow-up in 6 months duration. Unfortunately, due to the pandemic of COVID-19, the patient had skipped the 6 months recall, and she came for the follow-up delay by skipping at least about 5 months and performed another follow-up mammogram on the August 2019. Now, this is the new mammogram. which you performed late from the follow-up that we suggested for her. You can see the abnormality.
I think the density has increased.
Yes.
Okay.
The density has increased. It's seen in the mediolateral oblique view as if a linear increased density.
Now a patch. It's more or less not a symmetric, it's rather a patch with consolidated areas.
Maybe.
Yes. Any other items have newly developed or more evaluated?
And also, I think the lymph node become more denser and increase in number.
Yes, it's more pronounced at the limited axillary view in the mammogram. And then by doing the comparison, here is the asymmetrical density. Okay, it's more evident in the 2020, August 2020. And we have this area, this linear line going through from the nipple and areolar complex toward the focal asymmetry. It's obvious here more than the other mammogram. It's more established. We have a track, more or less. Okay, now we can give the mammogram a Barratt's or still is a Barratt's 0?
No, at least 4.
4. So this time in the follow-up, we're about to give the mammogram at that time Barratt's 0, but still we have to go with the lymph nodes. On the ultrasound, still we have the apparently looking like ducts with very areolar, very ductal abnormalities and increased vascularities. We have here the area of asymmetry. It's here more evident that it is an area of architectural distortion with increased vascularity related to it. It's more established here. It's not like the glandular tissue, apparently glandular tissue that was before in the previous ultrasound. And the nodes, we have cortical thickness. Now it's in 0.5, not just a subtle increase in the diameter with about only 2 to 3 millimeters. So the ultrasound will be given by Barratt's 4, I guess. Here the mammogram and the ultrasound 4, or we want to give it by Barratt's 5?
No, I think for no 4 and biopsy.
4B.
4, and we can see what goes through. You think we may use another modality before going on to biopsy, or just we stuck to these findings and rush on to the biopsy? Doesn't give. Do you want to give the chance to the patient to have another modality? Maybe we can downgrade the Barratt's and save the patient from the anxiety of doing an interventional procedure.
I think if we're in a multidisciplinary team, we would have chosen to perform a contrast study before, just to delineate the abnormality before the biopsy.
So what do you think of the contrast-based study? It's the MRI or the contrast-enhanced mammogram in such a case? What the contrast-based study?
No, I would prefer MRI. It's a deeply seated lesion, and we cannot see the actual through the posterior extent of the lesion unless we do an MRI.
Yes, I agree with you totally. I agree with you totally, because the lesion is deeply seated, the area of asymmetry, which is now developed to be distorted. It's deeply seated, and so we need to have a good discrimination of such area by the MRI. For now, we're going to give the ultrasound by Barratt's 4, and next we may give the chance for the patient to do MRI imaging, and then plus or minus proceed to the biopsy. Our MRI, this is the T2 weighted MRI imaging, the pre-contrast images. You can see the abnormality.
It's not very evident on this.
Okay, I may give finger focus images. You can see here the upper outer quadrant area is showing an area of distortion. The signal intensity is differential from the glandular tissue, yet a little bit higher, which goes with it's not a polymorphic cells or cells with having a high mitotic activity. And here we are going through the linear band of distortion mounting to the nipple and areolar complex. And the T2 star, it's more evident, I guess, the T2 fat suppression sequence. We can see the area very clearly. It's targeting the nipple and area complex and going back through down to the pectoral muscle, tracing the whole length of the breast. But we still don't know if it is of a solid or a cystic component, more or less. Maybe all of this turns out to be just a periductal mastitis. This is the reconstructed axial maximum intensity projection image, giving the whole extent of the mass or the pathology, the disease, and the nodes. This is the sagittal images, T2 star, and give the whole extent of the lesion as well. And the distortion is so much evident. And the tracking of the areola, the nodes also could be evaluated here. It's obvious that we have the asymmetrical cortical technique. This is the rest of the images. This is the enlarged nodes with asymmetrical cortical technique. And here, this is the post-contrast. I guess the extent of the pathology is obvious here. We are not dealing with the cystic changes or just hormonal imbalance of the patient, congestion, or area of hyperplasia. I guess it's, what do you think?
Asymmetric non-mass in a segmental distribution.
Yes.
I think it's a non-mass enhancement, taking a segmental area, giving heterogeneous clumped enhancement, extending from the pectoral muscle to the nipple. Actually, it's suggestive of something of ductal origin. The extent of the lesion is suggestive of something extending through the ducts. I think we have to take biopsy from this case.
Okay, Dr. Murat, your idea. Do you think you are now so much relaxed and you could give the patient another 6 months to follow up with 3 close interval follow-up, or just go for the biopsy and have the chance to know what it is? I guess it's emerging or what?
The patient was already assigned to BIRAT 4.
Yes.
Starting from the
Did
mammogram.
MRI downgrade or upgrade the BIRAT category?
No, it's of course it's pretty much consistent with the DCIS.
So much convincing that the patient needs biopsy and no time to wait. No time
it's
to wait.
really suspicious for the segmental non-mass enhancement, asymmetric non-mass enhancement in one side for DCIS. Yeah.
Okay.
It's raised my suspicion even more.
Okay, the suspicion is the distribution and the pattern of contrast uptake of such a disease. Okay.
Correct.
So we have the time signal intensity curve in order to confirm or a little bit to be evident about our diagnosis. We have here a plateau curve pattern with a rather high signal intensity percentage. We have in one it's 167% and the other one it's almost 160. What do you think? Do you think the time signal intensity curve have affected your evaluation? Okay,
not much.
No matter.
No matter.
Whatever the time signal intensity curve have a pattern, has a pattern. The morphology have its way.
Yeah, correct.
Okay. So the mammogram it was 4, ultrasound it was 4, and on MRI. I'm going to give it 4 as well until
4B,
doing my
4B or 4C.
4C or 4B, yes. So by the biopsy, on the ultrasound guided biopsy, it was a mixed micropapillary and herpetiform ductal carcinoma in situ, intermediate grade, and the patient have done mastectomy. My question now, again for Dr. Met and Dr. Heba Azam. When you suspect a DCIS, especially from the mammogram at the level of the mammogram stage, what do you consider the methods of investigation or going to pathway? What is the scenario you are going to think of in order to get the diagnosis as fast as possible?
I think MRI in the investigation of choice in this case, because even though it can delineate the calcifications, yet it can delineate the extent of the lesion. It's much more sensitive than mammography in cases of ductal carcinoma in situ. In some scenarios, some author reported that even cases with the microcalcification mammography that do not show enhancement on MRI are extremely low-grade lesions that do not need to be surgically removed. They can just be followed. So I think MRI is the best investigation that can give us idea about the extent of the lesion and the grade of the lesion. It will be much more informed.
And I agree with you totally, Dr. Heba. Yes, we need MRI examination, even if we have an evident pathology or evident disease here in the mammogram and ultrasound, because we need to know the actual extent of the disease, how to get the actual size of the disease by tracing the areas of contrast uptake. Now my question for Dr. Maher. Dr.
Yes,
Maher, do you hear
you
me?
hear me? Do you hear me?
Okay. I
Okay.
was just wondering about the treatment options for DCIS. And if there is a role for the presence of indeterminate axillary lymph nodes or pathological nodes, it affects the choice of the surgery, or it doesn't have any significance in case of DCIS.
Can I go back to the first image, the initial mammogram? Because I just have a comment on the this
Okay.
that I think it's from the start that we need a biopsy because we have a suspected lesion from our yeah from no the mammogram, not the
Okay, this
MRI.
is the
The
mammogram.
first one, not
Okay.
the first
From
mammogram that we decided
Okay,
for.
this is the first and second mammogram.
Yeah, the initial one. I think
Okay,
it
November
was
2019.
yeah, I think we need to take a biopsy from the deeply seated lesion in the upper outer quadrant, and I also yes, and I think that's in the CC view we have a clear para-areolar lesion in the upper outer quadrant that is also present in the MLO view. So with this picture, I think it's from the start that we should to take a biopsy and not to follow it. This is just the only
Actually,
comment.
what delayed this, such a decision because on the ultrasound, when correlated the image of the ultrasound with that site on the mammogram, we could not find anything except a pattern of a glandular tissue, apparently glandular tissue. It deceived us at that point.
So
And
yeah,
actually, the protocol of managing cases with focal asymmetries or a single view asymmetry, if you don't find an ultrasound correlate,
Yes.
maybe we could have asked for an MRI at that time. Maybe it would have been a good choice.
patients from the start, Russia, I think that we need a contrast or MRI from the start to keep it at PIRAT 3 and follow it, or to
But
upgrade it to PIRAT 4.
the thing which matters actually is that maybe if she came for her follow-up at the proper time, we would have found it a little bit earlier. She nearly stayed for يعني 5 months later than her follow-up date.
Yeah.
Yes, but
So
at
the
that
only comment
stage,
for this,
we are at the beginning. At this stage, we either do a close-term follow-up, and if this asymmetry increases in size or increases in density, we can proceed to other imaging modality, like what we did when she came to us.
Can I add something here, Dr. Rasha?
Yes.
Yeah, I agree if it's just a focal asymmetry and there's no other suspicious, maybe we follow up. But before we assigned it as BIRAT 3, I would have complete the workup of mammogram, meaning I would do a compression, cone compression view, or at least tomosynthesis to make sure that it is not a real lesion. And maybe if we could add these two steps, maybe you could have changed a bit the BIRAT, but anyway, if it's continue to be like just completely focal asymmetry, not real, we would have done the follow-up then. But this is what also I was thinking, just to add more complete workup for the mammogram before assign follow-up.
yeah, I totally agree with you, doctor. And this is my point at the beginning that we may need to add added imaging, either tomosynthesis or just or even MRI at first to keep it under follow-up. This is the only comment on this case from the start from the imaging on the imaging picture. And back to your question, Dr. Sahar, about the management of the
treatment
DCIS.
options, yes, and if the status of the lymph nodes affects your choice of surgery.
Sure, I have to take a fine needle aspiration cytology from the axillary lymph node before I decided the decision for this patient, because it may be a DCIS with micro invasion or and not represented in the true cut biopsies. So because the lymph node is suspicious in the mammogram picture and maybe on the ultrasound comment, so it's still indeterminate lymph node. So I have to take a fine needle first from the axilla to decide the nature of the axillary lymph node.
But
Actually,
this
this case is
prevents the
can
patient to
can
be
we have to finalize this case because of the timing. So we can say that
yes.
we missed doing further investigation for this case at her first presentation. Some of you said we should have done a tomosynthesis or a contrast study, although this is not the usual practice that is done, because we have a lot of cases with asymmetries which turned out to be just a focal fibroglandular tissue, and sometimes even the tomosynthesis isn't of that benefit, but maybe in this case, because the breast density is not so dense, it would have added, although the lesion is deeply seated and we cannot actually decide whether we have to do something more or no. She was given a follow-up.
I would like to add something, Dr. Rasha, very briefly. I would like to add something very briefly, that the pathology of the case with microcapillary ductal carcinoma in situ, which has a high incidence of contralateral and recurrence. And so if I'm facing a case of ductal carcinoma in situ, microcapillary type on biopsy, I have to do MRI imaging, even if I hadn't do it before the biopsy. I should do it because it has a high incidence of contralateral and bilateral and recurrence in the symptoms. Okay.
Okay, so we can now proceed with the second case with Dr. Iman Awis. I think everything is going well now. Can you stop?
Yes, I have.
Thank you, Dr. Rasha. Thank you, my professors and colleagues and the panelists. I will share with you a very interesting case we had during the past few months during the COVID outbreak. I'm presenting for you a 44 years old female patient. She had a personal history of left breast conservative therapy on 2016, about 5 years ago. She had been presenting at the clinic for follow-up since 2018. She was diagnosed before with invasive ductal carcinoma, a stage 1 disease back then. She returned, she has no family history. She obtained radiation therapy and targeted therapy for 2 years, and she presented for her routine follow-up on March. Actually, this was like 2 days before the government announced the quarantine lockdown and curfew regulations in Egypt. And as you can see, there is a scarring in her left breast owing to the previous surgical intervention. And also here you can see a grouped suspicious microcalcifications in this region. Morphology presenting as coarse heterogeneous. This is her CC view. It is clearly seen in this area. Almost around 3 o'clock in the left breast, middle third. And I want to show you also something here. When we look back at her prior mammograms for comparison, as you can see, there has been already calcification in this case, segmentally distributed. And when she first came in 2018, she was already reported as suspicious by RAS4, and a biopsy was performed from this area and also an MRI. And the biopsy turned out to be fat necrosis, no malignancy was identified, and also her MRI was negative. And the patient didn't wish to go for more intervention as there's no definite malignancy in the procedures she performed. So she wanted to stick just with her routine follow-up. And actually she did. She used to had a mammogram and a 6 months MRI and another 6 months mammogram, and so she's following up every 6 months. And this is her 2019 mammography, and the calcification was almost stationary, as you can see. And also we noticed some improvement in the post-radiation edema, and so this was more assuring, but we kept her on BIRAT 3 for routine follow-up. But when reviewing her images on March 2020, we noticed that the calcifications are somehow definitely changed. They became more suspicious when it comes, the distribution has changed from being segmental to grouped. The calcification itself became more aggregated and closer. And also, I can't tell if there is some subtle distortion also in the parenchyma. They became more confined to the parenchyma than there were some in the fat. There is no longer seen those lucent centers of REM calcification seen before when it was reported at fat necrosis. This is also her MLO for comparison. It's clearly seen how the distribution has changed from being for all this area to this area. So this definitely warrants further investigation and reported as BIRAT 4. And as she is a high-risk patient during the COVID-19 outbreak, we still give them a priority for the recalls and workups. So we recalled her and advised for biopsy and scheduled for MRI also as well. As much as we were happy that she came for her follow-up on time, she skipped her scheduled MRI visit and the biopsy, and she was afraid to leave the house again during the outbreak as corona cases numbers kept rising and at this time. And she also noted that in her visit, we at the clinic were of less working hours, a limited number of personnel at the clinic, only dealing with one case at a time per hour, unlike our regular routine before the COVID-19. So she felt that there's something serious going on, and she did not want to leave the house again during the outbreak time. But unfortunately, the patient came back later at the end of July, presenting with increased skin thickening as she reported, and also recently felt lumpiness in the left breast. Well, she came back at the end of July 2020, like 4 months later from her mammogram in March. And we performed limited mammography for her and also ultrasound to see these changes, what's behind them. As you can see, we found the newly developed grouped calcifications almost similar to the one seen at the outer aspect, but now we can see at the retroareal region and the inner aspect. I will show you also more illustrated images for them. Also here in the ultrasound, you can see this evident skin thickening of 6 millimeter. We also could identify by ultrasound this ill-defined hypoechoic areas with echogenic calcific foci within, corresponding to these newly developed areas of calcifications. It's also seen at the scar site. Also, in the Doppler scanning, we saw different types of arterial vascularity, which some were suspicious. This should not be seen in a post-conservative therapy patients, especially near the scar. So this raised a lot of suspicion of local recurrence. This is digital magnification of the mammography to show you more the distribution of this suspicious calcification seen in this patient. We can also see in comparison with the priors, we can see the chronological change happened to this patient calcification. And also, if you can notice like a year difference between this one, but this rapid progression of the disease during this short term of visit, this also was surprising to us. Also, I will show you, as you can see here, that the difference, this was only seen in March, but the difference here seen with the calcification, the distortion, and also the skin thickening, it was not there before, only 3 or 4 months prior. This is her tomosynthesis. Can you see it? It's playing.
Yes.
Yeah,
Yes.
it's clearly seen the distortion associated with these calcifications and the skin thickening. So to avoid any more delay, we managed to book her an MRI and biopsy at the same day. So we will not have more delay, and she will not have to leave the house twice. And MRI was requested for more accurate local staging, and her MRI confirmed the same extension of the disease we identified by mammography and ultrasound. You can see here, this is the T1 subtracted images post-contrast, showing this non-mass enhancement of all the left parenchyma and the left breast. And the T2 images, we can see the distortion also in the fat planes surrounding this parenchyma. I added the spectroscopy images just to illustrate more for you the enhancement of the whole parenchyma involved and with the calcifications in the mammography. No chest wall or regional lymph nodes involvement, although there were no washouts in her kinetics curves, but still this enhancement should not be seen in the post-conservative breast. At least we are at 5 years interval now in her follow-up. So this is definitely suspicious and raised the suspicion of local recurrence, definitely. Nothing was there in the other breasts and the right breasts, but also you can see here the enhancement seen in the left breast. Her biopsy results came out in August 2020, confirming the local recurrence of invasive ductal carcinoma grade 2. She was hormonal receptor negatives, HER2 positive, and also in situ components were identified of DCIS comedotype. This case was really interesting because she has interesting finding in her mammography. I want to discuss with you, my professors and colleagues in the panel, mainly if we can start with the impact of the patient delay on the surgical management of this patient. Is she still a candidate for surgery first, or requires neoadjuvant chemotherapy? And if there is an impact or difference, can we describe the difference between the two scenarios if we proceeded with the biopsy and MRI in March and now in August recently? Dr. Maher, if you can come in.
Show us the
Thank
image.
you, Dr. Iman. Thank you very much for your this interesting case, and for all of us, it will be missed from the start, because the early post-operative or the early imaging post surgery is like a dystrophic calcification. So
Yes.
we will follow up, but it's developed the local recurrence, and when we look to the pathology, it's an aggressive tumor. It's in here to enrich it, I think. So it's suspected to be locally recurred. But in regarding the surgical management and the delay, I think the edema is increased with the time, and I think we have to have a comment on the axillary lymph node to take a decision now to start from neoadjuvant treatment or to
She
have a local control.
already removed her axillary lymph nodes
Yeah,
in the first
I know, but I have to confirm now there is local
yes, of
recurrence in
course,
the axilla or not.
of course.
So
would you?
yeah, so I have.
Can I
Okay,
can I ask Dr. Amani and Dr. Shaima, would you give such a patient neoadjuvant chemotherapy, or there is no use, just proceed directly to mastectomy?
Dr. Amani, would you go first? Okay, I would go first, Dr. Rosha. You can hear me?
Yes.
Well, generally speaking, maybe if we had seen this patient at first images a few months before in March, apparently she had a much earlier disease or recurrence, and probably the surgery would have been easily feasible. I'm not sure if this recurrence is accompanied by bulky axillary lymph nodes or of her metastatic workup is free, but I'm expecting that it is. Now, after this
Her metastatic workup was free, yes. Yes, her metastatic workup was free.
The axilla is very important.
The axilla, of course.
Yes, yes. This is why we asked for the MRI, and they were all free. The infraclavicular, reciprocal, all the regional lymph nodes were free. Only the breast was involved. Yeah,
very
and
lucky.
she's very lucky. Yeah.
Yes. So now, after this time, it's a bit of a more advanced disease, but if clinically this patient can go for upfront surgery, yes, we probably in our MDT we would go for upfront surgery. And then we would see if we can give what we would call pseudo-adjuvant treatment. For your question, Dr. Rasha, would we consider neoadjuvant? Yes, sometimes the recurrence is quite advanced and the patient would not really benefit from upfront surgery. Another point to take into consideration.
Sorry, which type of surgery you are going to do it?
Definitely mastectomy.
We are usually inclined for
we want to do
yes,
again.
failure after breast conserving surgery. We're usually inclined for a mastectomy.
Yes, and what about the edema, Dr. Shaimaa?
Sorry?
What about the edema? Would it be feasible for surgery with this?
That's why I'm telling you I would like to see a clinical image, because that's usually the surgeon would like to see a patient and examine her besides the images.
Yeah, it's my role.
Also for us.
Yeah,
another point.
I think from the image, I think the clinical examination is very important to decide to we have a flap to for mastectomy upfront or not. But the only available now is the imaging picture of the edema, and I think it's okay. It's ending up to about we have a flap in the lower part. It's very small, but the upper part is clear. So I think it's feasible for upfront surgery. And the surgery, it must be a mastectomy because the patient received actually a radiation therapy, so we cannot reconserve again.
Yes, yes. So it would probably be a mastectomy, yes. And if Dr. Meher, if I see this patient with Dr. Meher and he tells me it won't be feasible for upfront surgery, then we would consider giving her a neoadjuvant treatment.
Yes.
First.
Yes,
I have to say in the context we are more inclined to going for surgeries upfront because exactly because of what happened with this patient. We are losing patients follow-ups. Some patients are very intermittent and irregular in their treatments. So if a patient is feasible for upfront surgery and we are still amidst of the pandemic, we might have any second waves. So yeah, if the patient is feasible, we would definitely go for upfront surgery.
Yeah, she actually, I'm just telling you, she did have the upfront. She was upfront for the surgery, and she had already the mastectomy first, and it went well, thank God.
I would like to comment here.
Yeah. Yes. Yes. I was also want to ask the panelists about what do you think about the change happened and our routine during the outbreak work, and do you think that our efficacy of our routine modalities used during the COVID-19 have changed? Should we have used more sensitive imaging modalities for our high-risk patient during the COVID outbreak, especially for the high-risk patients?
Yes, we can have Dr. Amani tell us, do you recommend for more more imaging, advanced imaging modalities to your patients during the pandemic, or you just keep to the mammography and ultrasound, to the routine imaging? Dr. Amani? Okay. Okay. Dr. Shaimaa, could you please tell us? Do you recommend for more advanced imaging for your patients during the pandemic, or you just keep to the ultrasound and the mammography?
No, actually, we were in much need of very good patient selection during the pandemic. I didn't want to waste my slots on the MRI and the contrast enhanced mammo on any patient. But definitely a patient like this one, I would have, of course, and you already had an MRI reserved for the patient. What we
Yes,
have
we were
learned,
right to ask for an MRI for this patient.
yes, yeah, this patient, yes, we would have definitely gone for a more sensitive imaging. But we were trying to be quite stringent when to use our slots because we were cutting down the numbers of patients, as you know.
Yes.
Our problem actually, and what we learned
And
during the pandemic is the need to, for an outreach system to always communicate with these patients. We call them the hot cases, the patients we need to bring back even during the pandemic and convince them to come for their required workup.
Yes, we're running out of time and we're left with the third case. Dr. Sarah Zetoun,
Okay.
stop sharing your screen, please, Iman.
I would like to present today a 51 years old postmenopausal female. She complained with right breast mass on December 2019. She was completed her investigation and proven to be IDC on January 2020. This is her imaging on January 2020. We have here about 5 centimeters mass with some sort of axillary lymph nodes. There were not, the fine needle for the axilla was non-specific lymph nodes. This is this ultrasound images. And there was a supraclav lymph nodes. The second look ultrasound suggested that the subcentimetric lymph nodes too small to be characterized or to be fine needled. This is the imaging. The CT was free, and her initial MDT decision on January was right simple mastectomy and sentinel lymph nodes. The patient lost the surgical appointment visit due to the COVID-19 outbreak, and she returned on August 2020. Clinically, she is now presenting with skin attachment on the right breast tumor, staging T4N2 with large axillary lymph nodes. The new imaging revealed the upstage of the patients, and the CT was free, and a new fine needle from the axilla was done, revealing a positive axillary lymph nodes and progression of the size of the tumor 5.5 from 4. This is the ultrasound. And her final MDT decision on September 2020 was neoadjuvant chemotherapy, then MRM. I think
What's noticed is that mostly the patients, they abstain to continue their management because I think we as doctors, we did not stop providing them with the care necessary for them. Maybe yes, we postponed some non-emergent cases or this, but most of them, it was from the patient side maybe.
Yeah, I have a question, Dr. Rahma, regarding this.
Merit, can you higher your voice, please?
I have a question regarding what you just mentioned about what is, we need to review what is our role as a radiologist in the pathway of patients. As you said, 6 months, in Western countries, family physician, family doctor, it's his or her responsibility to make sure that the patient go back to the breast center. But here in our country, I wonder who's responsible to make the patient come back for a follow-up or when the biopsy result is malignant, who's responsible? Is the radiologist or the pathologist or the surgeon to make sure that the patient come back to receive her result or to do the 6 months follow-up?
Diagnosed cases are usually discussed in the breast cancer tumor board, but actually it is the responsibility of the secretarial office of the board to follow up these patients and tell them to come back. But normally for screening, the patients, we don't have, in Egypt, we don't have a reminder for the patients like they do in the Western countries, because we don't have an established national screening program to do so. But on the level of for
And we
example,
don't have family doctor.
yes,
We don't have family doctor. So I think it is done case by case, and every medical care different from the others.
Yes,
sometimes it is the responsibility of the radiologist. Sometimes it is the surgeon. Sometimes
totally agree with
pathologist.
Yes, Dr. Rasha, I totally agree that it's for per patient and per institute. And actually, as Dr. Rasha mentioned, that the tumor board secretaries always follow the patients that missed their appointment after to be diagnosed as a cancer patient. And we have faced a problem with many patients that we give her an appointment, and the patient that does not came to the hospital because they are fear of the COVID-19 pandemics, and they seek some medical advice very close to her residency, and some patients are missed because they are have many fears to come to the hospital. So it's an a combination of fear and the personal communication direct with the patient on the level of institution, as every institution has his own policy.
Yes,
Either
it's
be
regulation.
yes, it has for even the diagnosed patient or the screening patient to re-come again with a message or not. But many patients are delayed because they are having fear to come to the hospital, and we have for example give an appointment for a patient more than 3 times, and she does not attend because she is not from Cairo, and she is very fear from the pandemic, and she decided to delay after the it come it fear to be safe.
Yes, I feel that we as breast health care providers, it's our duty to transmit to the patients that do not fear the coronavirus, but because you're not sure you'll get it, but you actually have a breast cancer in your body, and you will die from
Yes.
this breast cancer, not from the corona. It's our
So
duty to transfer this message.
yeah, we don't stop providing the service as you mentioned, and we continue to keep in contact with them. But it is the situation that we face that some patients still fear to come to the hospital from
Yes.
the for the fear of the Corona-19 pandemic.
If you allow me, Dr. Maher, can you hear me now?
Yes,
Yes,
we hear
yes,
you.
Okay, very good.
And welcome.
Can we ask for the patients who are living away from the Cairo to make their investigations in their countries, not making them, or in their cities, not making them coming to the central zone in the Cairo? I think this would be more feasible for the patients, making them more comfortable with not moving too much to come to the Cairo.
I think we do this for some patient and for everybody that I give the give doctors the authority to receive patient inquiry during the Corona-19 by phone. That's not for they cannot attend from Cairo, and sometimes we ask him to do some imaging very close to there, as you mentioned, Dr. Amani, to confirm that it is not a progression of the disease or a malignant case. And when it's proved to be suspicious, we ask her to attend whatever the situation. Actually, we do this.
Yes, but I think the idea of going to a healthcare facility during the pandemic was in itself a problem to most
Yes,
most
yes, it's another problem.
yes, and that's why I think it's not only a problem in our country, worldwide, everywhere they are now seeing many cases with advanced disease, and many cases who have known they have something in their breast for months and they couldn't come. When the pandemic has partially subsided, they are now they feel more comfortable that they can go or to seek care. And but actually we are seeing a lot of advanced cases. I think the time of the panel has we have I think finished the time, and actually I want to thank you all for your efforts and for sharing in this panel and this fruitful discussion. Yes, and thank you all.
Thank you.
Thank you.
Thank you.
Thank you.